guys, so today we'll have a presentation in our radiology journal club. This presentation is about the multimodality imaging of liver infections, the differential diagnosis and potential pitfalls. As we know, liver infections are a very common findings, very common complaint of the patient. There is multiple pathogenesis, multifactorial, a lot of variable imaging appearances. We can make a very good job in helping the clinicians in the diagnosis, treatment, and follow-up. So today, Dr. Saif, inshallah, will present the lecture, and we'll see if we have any questions.
First, we will start about bacterial infection. Bacterial infection of the liver can be present either as a biogenic liver abscess or bacterial granulomatous like TB, or acute bacterial hepatitis, which is rare. Bacterial infection of the liver can be categorized biogenic abscess. The pathogenesis of liver abscess either ascending, cholangitis, hematogenous dissemination, gastrointestinal infection, or contiguous separate. An ultrasound abscess will be if it's less than 2 centimeter hypoechoic or ill-defined area with distorted hepatic echogenicity. If large abscess may be hypo or hyperechoic. Biogenic abscess may simulate solid lesion, so we can use Doppler to see if there is a vascularity inside it, and through transmission to differentiate it from a tumor. Or this is ultrasound of an abscess, heterogeneous ecotexture, no Doppler, with thick wall, classical picture of an abscess. CT feature most common at contrast enhanced CT, well-defined low attenuation, round mass with an enhancing peripheral rim. Abscess can be non-loculated, single multiloculated, solid, or multifocal lesion. The most important sign in contrast CT is the double target sign. Hepatic abscess in contrast image with central low attenuation fluid and surrounded by high attenuation inner ring and low attenuation outer ring. The inner ring will take enhance in early phase, and the outer ring will take in the delay phase. This is a CT image, and this is the early phase. We can see the hypo outer and hyperdense inner margin of the abscess. In the delay phase, both of them will take the contrast and seen as single layer. Here. The other sign is the cluster sign. Multiple small low attenuation lesions aggregate in localized area and coalesce into a single larger abscess cavity. The other sign is transient early wedge shape or circumferential segmental region of hepatic hyperenhancement at dynamic CT and MRI. Equilibrate in late phase associated this with hepatic abscess. This is the result from reduction of portal flow and compensatory increase in arterial inflow of the area. At MRI, the abscess will be seen as the hypo-low signal intensity in T1 and high in T2. The wall of an abscess will be hypo in both T1 and T2. And in diffusion weighted MRI, it will show restricted diffusion. This is MRI of an abscess. This is the axial T2 MRI show double target sign. And this is contrast enhanced. It will follow the CT scan and taking the contrast, just like CT in dynamic, early contrast. Cells may be present in about 20% of liver abscess, and it's characteristic for liver abscess, but caution to take about if it's sometimes seen in missed codes. If we have previous surgery, we will see it as trach, gas-free area, or in some cases, if there is any history of tumor ablation or any interventional procedure. This is axial contrast enhanced CT, the CAS, like the colon, and this in MRI, also the signal intensity of it, like in the colon. This is the diffusion weighted MRI. This is hyper intense in diffusion and restricted diffusion, low signal, sorry, and IDC map. An additional imaging feature of Klebsiella pneumonia infection is turquoise sign due to numerous thin purpurizing internal band that resemble the turquoise mineral. This is the mineral, the band, take contrast. Sorry, Doctor, here. Move here, but
on the screen it's moving. Yeah. Just reduce selective direction. Pointer options. Okay. So multiple rising signal intensity and density on CT and MRI. This is a very typical finding of liver abscess.
Differential diagnosis for its hepatic tumor may mark liver tumor, however, abscess still follow the contrast enhancement. We discussed it before it. And here it's a CT scan of a tumor. Axial contrast enhanced CT obtained in the early arterial phase nodule with a target appearance, with a central early enhancing area similar to the liver parenchyma low attenuation rim. In axial contrast enhanced delay phase, all of it will take. Also, the inner margin of the of the wall will be irregular or nodular. This is in abscess, but in tumor. But in abscess, it will be smooth of the same thickness.
Sclerotic from the center to the peripheral, the inner margin of the wall, nodular and irregular thick. While the SSC will have a wall rather than nodular.
This is another case of necrotic tumor by hepatic abscess. Here we can see the irregular inner margin of it and also calcification inside it, and the dynamic study for its wall enhancement in contrast study can help us in diagnose this is a tumor, but still it's sometimes very difficult to distinguish between them on imaging study alone. Another differential diagnosis is small liver cyst or biliary cyst. Microabscess, sometimes it will be hypo NT1 and hyper NT2 with faint rim on faint enhancing rim. Restriction on diffusion weighted image feature can help us, but small simple cyst.
Or peribiliary cyst. Usually you might see them normal cyst, no diffusion restriction, no contrast enhancement, no masseter, no surrounding edema, nothing. While all these features are presented as abscesses first. Second, you might see just sclerosis. So if you see a sclerotic liver, this is not just like this is lower abscess. If a normal liver, more likely to have abscess is lower abscess. Plus the additional features of restriction, diffusion, contrast enhancement, coloring side, cluster side, and all of the other findings. Exactly. And the abscess diffusion study tumor on yes, exactly. But for example, the previous case, the focus of classification helped us exactly that this is a tumor, it's not a abscess. But there is no focus of classification, it would be very difficult. Okay? Maybe you have other clinical criteria, like for example, white blood cell count, won't help in changing us toward the actual abscess. Okay? So you have a clinical approach. You need all the clinical data, not the imaging data.
Other one is biliary hamartomas, which will show thin rim enhancement on delay in gadolinium image. However, in case of biliary hamartoma, neither periregional edema or restricted diffusion will be seen. And the absorbable hemostatic material, we mentioned it before, you may see a gas inside it, complex fluid collection. It's usually seen in surgery about 1 month. This small cholangitis abscess mimicking cyst, and here we can see intermediate signal intensity for regional edema around hyperintense lesion. This is T2 weighted image.
You can see the surrounding edema, very mild, very you are advantage, but not very obvious. But there's some edema surrounding it, indicating that this is not a single cyst. There's something wrong over there. If you go to us and you can see the enhancement, it's very obvious. Okay? So this enhancement plus the surrounding edema, multiplicity small, then should give you in favor of
Also, we can see the wall enhancement here. Tuberculosis seen in immune-compromised patient. Tuberculosis can manifest as micronodular or macronodular. Macronodular is the most common, can be present as a small multiple small nodule, or sometimes coarse texture of the liver, just and hepatomegaly. Yes, this both of them is will come. The micronodular. Okay. The open detected hepatomegaly may be the only abnormality. Both of them about micronodular. Detectable on sonography may reveal diffuse tiny non-specific hyperechoic nodule. However, could be just hyperechoic liver, diffusely hyperechoic, and can manifestate as half to 2 mm low attenuation with no discernible ring enhancement. CT with healing small scatter classification. This is in CT. In MRI, macronodules are hypo in T1 and hyper in T2.
Sometimes it's so small that does not always
It's very difficult to differentiate it from other sarcoid lymphoma, fungal infection, but coexistent, as say Dr. Ahmed, in spleen or in the lung, or calcified lymph node in the can help us in the diagnosis. Macronodular hepatic is rare. Nodule may be single or multiple, and the findings are not specific in diagnosis, just a nodule, small. PCR and acid-fast bacillary testing may help in the diagnosis. It's just nodule hypo in CT and low signal in T1 and high in T2. This is disseminated tuberculosis infection. Contrast enhanced CT show multiple tiny hypoattenuated lesion in the liver. This one, small one. And here we can see the retroperitoneal lymph nodes and other nodule in the spleen, which help us in the diagnosis. Peritonealosis usually occur in child or young adult with history of cat scratch, present with scratch with periregional lymphadenopathy, sometimes constitutional symptom of fever and pyrexia of unknown origin. Hepatic can be present as 3 to 30 mm at ultrasound, vary in appearance, but most commonly it's hypoechoic nodule. On CT are hypoattenuating, but who can present in contrast enhanced CT can present in a 3 picture, either still hypoattenuating or isoattenuating or faint rim enhancement around it. At MRI, it will be low signal in T1 and high in T2. This is CT scan, contrast enhanced CT. Can show hypoattenuating nodule scattered in the liver.
So we have other differential is classifies or losses.
Yeah.
Usually
If it happens in patient with HIV infection, may cause cirrhosis. Benign vascular condition that may simulate hemangioma or other vascular tumor. At ultrasound, multiple small round hypoechoic lesion can be seen in the liver and spleen. CT, low or high attenuation lesions scattered through of the hepatic parenchyma, and in T2 MRI show hyperintense focal lesion. Enhancement may be globular, centropetal, or centrofocal, but it's usually continuous with no washout in delay phase. Little mass effect on neighboring hepatic vessel. Differential diagnosis for it is hemangioma and hypervascular metastasis. Hemangioma, globular discontinuous contrast enhancement, while it's continuous. In hypervascular metastasis, hypo to iso to liver, parenchyma and portal venous face imaging. And the clinical history is also helpful to suggest the diagnosis. This is MRI, axial T1 weighted image, ill-defined nodule in the liver, and this is T2 fat saturation, moderate high signal intensity, and in contrast enhanced hypointense right hepatic nodule with irregular continuous peripheral enhancement around the lesion, and on delay phase the enhancement within the nodule and all the nodule take the enhancement. Viral infection of the liver, hepatitis, many type A, B, C, and A. Many state may be present normal. The constitutional symptom of jaundice, fever, headache, but for us as a radiology can present either at ultrasound hepatomegaly with decreased parenchymal echogenicity with portal trait, hyperechoic portal trait, starry sky appearance of the liver. CT.
Ultrasound decrease echogenicity, or CT scan or MRI increase T2, decrease T1.
Extrahepatic finding for gallbladder thickening. It's important. The differentiation between and then acute cholangitis, it will not contract that after fatty meal.
Very important to keep in mind.
But
if you see the liver you have one of two possibilities, either cholangitis calculus or cholangitis, or hepatitis. Okay? If it is the standard, this is due to calculus cholangitis, not for stool. Not the standard gallbladder, this is due to hepatitis. Okay? Either due to hepatitis, because gallbladder is not the standard. So there's no story side. Keep that in mind. It's a very good prognosis of daily practice, like ultrasound procedure. Contracted, there's a long history in chronic cholangitis, some more classification.
Many ultrasounds, and many and I have seen at least 80% of cases ascites. Of course, why did you not mention that?
Because if you see ascites, it's a very common differential diagnosis of the cause of the ascites.
But if you don't have sometimes
so exactly, you have seen as normal. Sometimes economic, sometimes gallbladder.
ascites is common. But on the basis,
Yes, of course, ascites in general is because of gallbladder altogether. So there is not a large overlapping between the findings. You need to cover everything. So you might have ascites to define result.
in these cases there are symptomatic, there are jaundice.
More severe.
Probably not. Moderate ascites, moderate gallbladder.
No,
This is MRI. We can see edema of the gallbladder wall and even in the falciform ligament, periportal. Parasitic infection of the liver. We have the amoebic liver abscess, more common in male.
As amoebic liver abscess, to know about important things are precedence for tuberculosis. Surgery is not necessary. Okay. Sometimes radiologically you might see abnormalities, but the patient is doing well. Like after treatment, he took treatment, it's getting better, it's okay now. You do some and there is no abnormality. So would you continue treatment, establish treatment from the beginning, or you do nothing? You do nothing. The radiologic findings last behind the clinical. It improves, but the radiologic is still something there. So just
This one? Usually it's unilocular and subcapsular, oval in shape mostly, but many times sporadic infection, could be bacterial infection with it. So diagnosis from radiology alone is difficult, but as Dr. Ahmed, just by single treatment with metronidazole is enough. This is CT scan contrast enhanced. The target sign can see here, very obvious. Just like most
it's more grammatical. Amoebic liver abscess, you might give reminders of retrolytism, and that's it. You don't go home, that's it. Nothing. But the radiologic findings might take up to 2 years to resolve. So not only to find something, it's well, that's it, not too well, it's nothing. The radiologic finding I found this as well. Some sort of intervention, like it's larger in size, and it's some sort of aspiration or surgery. I don't know what it's some intervention. While anything just by drug therapy, most of the time it could be very difficult.
animation in the abscess if it's less than 5 cm, either aspiration or antibiotic, same result, no difference. More than 5 cm, better aspiration or surgery. This is for hydatid cysts. The mature hydatid cyst consists of 3 layers: the endocyst, inner or germinal layer, the living tissue, and the ectocyst, middle layer. It's acellular laminated membrane secreted by the germinal membrane, and the pericyst outer layer is a thick fibrous capsule corresponding to host response of the liver parenchyma. The ultrasound feature of hydatid cyst, according to the World Health Organization classification of it, we have 6 stages: either cystic lesion, an active unilocular cyst is seen with uniform anechoic content and cyst wall that's not clearly visible, and Echinococcus granulus cyst type 1, active unilocular with fine echo due to hydatid sand and seen to fall dependently if we turn the patient, and this is snowstorm sign. 3, we have they classified, this is type 0, this is type 1. CE type 1 this, and this is CE type 2. Multivesicular multiseptated cyst with a well-defined wall, spoke wheel pattern, daughter cysts. inside it. And CE type 3, the water lily sign is due to decreased pressure inside the cyst and co-separation of the detached membrane floating inside the cyst. CE type 4, it will be hypo or hyper contact, pseudotumor appearance, manifest as ball of wall sign, indicative of degenerating membrane. Most cysts of this type are inactive. But at type 3, stop.
Then they go to a ball of wall sign. Then the type 5 system by complete
That's everything. Everything is that. This is ultrasound, which show heterogeneous mass with mixed hypo and hyperechoic pseudotumor. Like this is ball of wall sign.
Everything is called out. A lot of the complex are there. Because still classified.
This is by CD scan, like the spoke wheel, I think, appearance. CD finding could be molecular with the daughter cyst partially calcified, densely calcified. A densely calcified cyst is again a marker of non-viability. CTO can show higher connection on non-enhanced image and daughter cyst by CT. The matrix will be of mixed iso dense, but the daughter cyst hypo, the fluid density.
While the matrix is from the small problem, it's a little bit dense first. Second, the person asked about enhancement. Since the cyst is not from the body, it does not take nutrition from the body, no blood supply from the body, the cyst itself, the endocyst, and the cyst is not enhanced. While the endocyst, the fibrous layer, is from the body, and it's active. So you might expect some progress, but not this time. This time it's progress. Starting to die. What does it say? It is alive, but starting to die. Yeah, the water release is ruptured. It won't go into multiple bacterial system. It's not dead yet. It's starting to die. Exactly, but they are alive. Inactive but alive.
At MRI, both T1 and T2 of the pericyst appear as a hypointense rim because of its fibrous composition and calcification. The highlighted matrix show intermediate to low signal intensity on T1 and intermediate to high signal in T2. The daughter cyst will be bright in T2, as fluid near to CSF. There is no enhancement of the cyst content, including the visible step. We have intracystic fat. If we see a fat inside the hydatid cyst, it's an important sign of that there's a communicating rupture of the cyst to the bile. And this will enter differential diagnosis of fat containing tumor like hepatocellular adenoma or carcinoma. This is the daughter cyst. This is T1. And this is T2 often, and this is T1. this is the faint enhancement, the outer wall, but there is no enhancement in the septa or the inner. Differential diagnose biliary cyst adenoma and adenocarcinoma. But the tumor show enhancement of the septum or the wall. As we mentioned, the hiatus cyst will not show this. Another is hemorrhagic liver cyst or giant bile duct hamartoma, and this will be hyper in T1. Hydatid cyst, leading into hydatid cyst, it's very rare to occur. This is hydatid cyst. Comparison. This is the hydatid cyst, and this is the biliary cyst adenoma. We can notice the enhancement of the septum, while in hydatid cyst, no enhancement. Simple liver cyst. Sometimes it's very difficult to differentiate between hydatid cyst if it's early.
Any cyst you see in the liver, you cannot, like somebody say this is simple or this. You always have to suggest it.
One thing about differentiation of simple liver cyst with hydatid, especially here, equipment hydatid. That's 0-1. The role of diffusion is not as measurable in differentiating simple cyst and
well, usually the cysts that are difficult to differentiate are the small hydatid from the super small size usually. The small hydatid cysts are usually unilocular. Okay? Because the bigger hydatid cyst more likely they will be not a cyst, sign, I don't know what. So, small cysts in the liver, it's very useless to suggest doing MRI just to see the diffusion around the liver. To see the diffusion, you know whether this is simple or hydatid. Yeah, you are talking about loosening the liver cyst, you're sending a patient to an MRI, liver to an MRI, just to be sure whether this is hydatid or simple cyst. So, it changes the appearance, it's more likely to go like that. Because the contents are scones, not pure water.
This is MRI of hemorrhagic cyst. It's high signal in T1, low in T2. Fatty acids.
Small bowel, okay? It has two phases. One kind of phase and big phase. It's got to extend the gut, and so it gets through the parenchyma, the parenchymal phase, into the big biliary ducts. Okay?
During its route, it will penetrate the liver and parenchyma. Sometimes it may die from mechanical and will cause local inflammation in the area, or it will reach the biliary duct and we can see the flux mature in it or the echo of it. Ultrasound, usually subcapsular, confluent, ill-defined hypoechoic. This is the parenchymal, and the biliary as echogenic inside the biliary duct and dilated the duct. Dilate the duct. At CT, also subcapsular, ill-defined border, hypodense. This is an ultrasound of it, ill-defined hypoechoic area. And this is the CT scan. We can see it's from the capsule and migrate toward the hilum.
By all modalities, there's no way that you will think of or even parasitic infection in general without having blood xenophagy. So, increasing xenophagy in the blood is the main step to tell you that this is mild, we are treating mild parasitic infection. Okay? And anyone of us, if that this is without evidence of physiology, you will never say any sort of parasitic infection. You'll go for a tumor or I don't know, for an infection or other. Remember, the infection that doesn't go along with this. When you have xenophilia, this is most likely some sort of parasitic infection, then you go to get bacterial infection.
By MRI, we have 5 patterns: perihepatitis or capsular inflammation, subcapsular, periportal, defined linear tract, segmental area of hepatic inflammation with geographical border, abscess with REM enhancement, focal post-inflammatory fibrosis. Again, it will be hypo in T1 and hyper in T2. Show restricted diffusion sometimes if it's be an abscess, and at MR cholangiography we can see ill-defined elongated hypointense filling defect in the biliary duct. This is an MRI. This is T1 hypo, and this is contrast enhanced T1, and this is delay phase contrast, and this is a diffusion.
See, diffusion, which is very obvious, because the parasite is moving through the liver parenchyma. It's leaving the cells of the liver, leaving a tract of restricted diffusion of inflammatory response. Something is moving in the liver. Okay, you can see the tract of the parasite from the periphery to the center. Okay, it's like we do needle biopsy. You can see the tract from the periphery to the center. The same idea.
And
it's very amazing images. You can see the parasite in the this is the parasite that's moving through the liver.
Differential diagnosis for it, it's Caroli disease and sclerosing cholangitis. We can say enhancing dot within periportal, non-enhancing hypoattenuating nodule can appear similar to the central dot sign seen in Caroli's disease. The linear periportal tract of the liver flac may simulate finding of sclerosing cholangitis. Intrahepatic cholangiocarcinoma, metastatic disease, and locally advanced gallbladder carcinoma may have similar imaging appearance to that of hepatobiliary fasciitis. However, linear tract and, more importantly, eosinophilia should prompt the consideration of it. This is a CT scan, and again the tract. And this is the hyper. Yes.
Might be something like Crohn's disease.
This is the sign.
Biliary fasciitis. Similar appearance to the central dot sign Crohn's disease. Okay. Xenophilia, we don't go for it. We go for fasciitis. Schistosomiasis is very common, especially in Egypt, plus previously. Very common disease in the highest.
We have two types, Schistosoma manasoni and Javanicum. Manasoni occur in large bile duct, and Javanicum occur in small, portal vein. It's occur in the portal vein, large portal vein, and the other in the small portal vein. At CT, the classical pattern is the presence of calcified septa that usually are perpendicular to the liver capsule, giving a liver tortoise shell or turtle back. Appearance other include low attenuation periportal band of fibrous septa separating uniformly throughout the liver. MRI, the septa are hypo to iso in T1 and hyperintense on T2. Periportal fibrous band marked delay enhancement after contrast. Liver cirrhosis may be associated sign of portal hypertension. Differential diagnosis is autoimmune hepatitis. It's difficult on the basis of imaging, so laboratory finding can help us in this situation. This is the schistosomiasis, and this is autoimmune hepatitis.
You can see in the first example about the terminal monocytes, it's just like a terminal one. Okay? In the lower, it's more heterogeneous pattern. Okay? With the context, of course, there will be much more proper evaluation.
Cholangitis, recurrent pyogenic cholangitis. It's also the infected just in the metacarcia ascend to the bile duct and to rise in the medium and small intrahepatic bile duct. This parasite induces a mucin secreting cell, so we can see dilatation of the bile duct. Sometimes we see the egg of it, but there is no obvious obstruction to the bile duct. And mostly we see the dilatation in the media, small and middle-sized bile duct, but the large or common bile duct will be near normal. By ultrasound, as we just mentioned, the egg show non-shadowing echogenic foci are cast within the bile duct. By CT,
it's a parasite that goes through the biliary tree. Okay? It will hold medium and small size because it's a small size parasite. Okay? When it's closed, it will occlude, resulting in the activation of the smaller size biliary ducts with normal size larger biliary ducts. Okay? And the activation is continuous. It's not multimodal, it's just from one point up. Okay, at the site of occlusion. But there is no occlusion or something that's not. So this is due to the parasite.
Sclerotic cholangitis, differential diagnosis for it, but it's caused severe thickening of the bile duct and discontinuous ductal. It is dilated bile duct with the hyperdense filling defect. Fungal infection. We have Candidiasis, one of the most common. Ultrasound can be summarized into wheel within wheel pattern, which consists of hypoechoic nidus representing necrotic fungal debris and inner hyperechoic ring composed of inflammatory cell and peripheral hypoechoic ring represent fibrosis, or bull's eye, similar to it, but there is no the inner hyperechoic, the nidus, the hypoechoic center. All it will seen as a hypoechoic nodule, which is most common, and echogenic focus of scar of calcification with variable posterior acoustic shadowing. The last pattern occur in later stage of infection and generally indicate early resolution. This is the bull's eye, hyperechoic and hypoechoic. CT, this is as present as low attenuation, and in contrast enhanced CT, we will see more of it than in native CT. MR superior is to CT and ultrasound, and it will be hypo NT1, hyper NT2, and intensity enhancement can be seen on gadolinium arterial phase image.
So
may show restricting
When you're looking for this kind of infection, you have to take arterial phase, not a portal phase. The enhancement is showing more or less on the arterial phase. Okay?
This is MRI, fast suppressed T2, and you can see it's hyper intense here, and this is axial diffusion, and this is fast suppressed T1, and a contrast enhanced arterial phase fast suppressed T1,
Let's see
hyper
glowing or
glowing.
post-contrast.
Histoplasmosis, common in fungal infection like candidiasis. But here in patient with the neutropenia mainly to get fungal neutropenia without the neutropenia. If no, seminal tuberculosis. So I think most of this. It's the most important. We have either it will be cystic or like solid mass. This is for if we have complex cystic lesion, either thick irregular wall, thick septum, will be either abscess or necrotic tumor. If it's abscess, we have double target sign, cluster sign, and area of transient enhancement around an abscess. Gas, if it's present, it's characteristic for an abscess. For necrotic tumor, nodular wall will be the wall of it will be nodular, no restriction on diffusion, and may see calcification. For thin septa, perceptible non-nodular wall, we have either hydatid cyst or cystic biliary neoplasm. For hydatid, no septal enhancement and daughter cyst, fibrous wall peripheral calcification. For cystic biliary neoplasm, septal or wall enhancement and nodular septa and focal wall thickening. For multiple small solid nodular lesion, we have nodular, well-defined or ill-defined. For well-defined, if it's the patient is immune competent or immune compromised. Immune competent with non-malignancy, it will be metastasis. If no non-malignancy, peritoneal gases in children, history of cat scratch, histoplasmosis, fasciitis considered nodule or subcapsular with linear tract toward the hilum, lymphoma sarcoidosis. If immune compromised patient, again, if neutropenic patient, invasive fungal infection, associated finding with the splenic or renal involvement. Of non-neutropenic patient, we have TB, we have bacillary biliosis, and Kaposi sarcoma. Nodular ill-defined, non-primary malignancy. If yes, metastasis. If no primary, we have intrahepatic cholangiocarcinoma, invasive gallbladder carcinoma, and fasciitis considered if linear tracts or hypereosinophilia are present.
This is a really nice and difficult